Welcome to another episode from Optic Surgeon, the ophthalmology podcast. Today, we're diving into something pretty serious. What happens when your vision suddenly goes in one eye, and, importantly, it's accompanied by pain?
Yes, it's an area that definitely warrants attention.
Exactly. We've looked at various sources to really give you a clear picture of what could be going on behind that pain and vision loss. So whether you're, maybe studying for your medical exams like NEET PG, or perhaps you're just starting your ophthalmology
Or
residency.
a GP, right? Often the first person someone sees.
Precisely. Or even if you're just curious about how your eyes work and, well, what can go wrong. We want to break this down for everyone.
Hmm.
Our goal today is really to outline key signs, touch on potential treatments, and stress why recognizing these conditions quickly is just so crucial for saving sight.
Absolutely. That mix, sudden vision loss and pain, just in one eye is a real red flag, like you said. It immediately tells us we need to think about things irritating the eye's sensitive bits or maybe inflammation kicking off those pain signals.
Mm.
So shall we jump into the first big one? Acute angle closure glaucoma.
Acute angle closure glaucoma. Yeah, it sounds intense. What's the main story there?
Well, think of it like this. Your eye has fluid inside, and it needs to drain properly to keep the pressure normal.
Right, like a little plumbing system.
Exactly. Now, in acute angle closure, that drainage system suddenly gets blocked. Bang! And our sources really emphasize this sudden blockage leads to, well, severe eye pain. It's like a pressure cooker building up steam inside the eye very, very quickly.
Ouch.
Yeah. And along with that really intense pain, you'll probably get blurred vision. Some people even see halos, like rainbow rings around lights.
Halos. Okay.
Because that pain can be so bad, it might even trigger a headache, nausea, sometimes even vomiting.
Mm.
So it affects more than just the eye.
Right, so it can almost feel like you're generally unwell, not just an eye problem.
It can, yeah.
So if someone comes in like that, what would a doctor be looking for during the exam?
Well, the big thing, the really telling sign, is how high the pressure inside the eye gets. Normal eye pressure is usually below 21 millimeters of mercury, or mmHg.
Okay.
But in acute angle closure, wow, it could shoot up to 40 mmHg, sometimes even higher.
40. That's almost double the upper limit of normal.
Or more.
Yeah.
And that extreme pressure puts just immense stress on the optic nerve, the cable connecting your eye to your brain.
I see.
Other signs you'd look for? The cornea, the clear front window, might look hazy or cloudy,
Because of the pressure.
likely due to corneal edema from the
Yeah.
pressure. Yeah. And we also look for what's called a shallow anterior chamber. If you imagine the space between the cornea and the iris, the colored part,
Mm-hmm.
that space becomes really narrow, almost closed off. And the pupil, it often gets stuck, kind of mid-dilated, and doesn't react properly to light.
So it really sounds like a perfect storm brewing inside the eye. And the urgency you mentioned, it's critical, right?
Absolutely critical. This is a true ocular emergency, no question. That super high pressure happening so fast basically starts to, well, choke off the blood supply to the optic nerve fibers.
Oh, wow.
And that leads to irreversible damage, potentially within hours if it's not treated. Think of it like kinking a hose.
Yeah.
The nutrients just can't get through.
So permanent vision loss can happen really fast.
Very quickly, yes.
Okay, so time is of the essence. What needs to happen immediately?
First things first, get that pressure down fast. Usually that means using pressure-lowering eye drops. Lots of them, often. And sometimes we need pills or even IV medication to really bring it under control quickly.
Right, hit it hard and fast.
That's exactly.
And then is there a more permanent fix?
Yes. Once the pressure's coming down and the cornea clears up enough so we can see inside properly, the definitive treatment is usually a laser procedure. It's called a peripheral iridotomy, or PI.
Okay.
So imagine the iris, the colored part, is like a curtain blocking that drain we talked about. The laser creates a tiny, tiny hole in that curtain off to the side. This gives the fluid an alternate escape route, bypasses the blockage, and helps prevent future attacks.
That's quite clever. A little escape hatch.
Pretty much, yeah. Relieves the pressure buildup.
Okay, that makes sense. Now, our sources also mentioned optic neuritis. We often think of it as painless, but sometimes there's pain.
That's a really good point, and it causes some confusion sometimes. Optic neuritis just means inflammation of the optic nerve. Now, it can happen behind the eyeball, where you wouldn't necessarily feel pain. That's called the retrobulbar type.
Right.
But when the inflammation affects the very front part of the optic nerve, the bit we can actually see when we look inside the eye, the optic disc,
Okay.
that part swells up. And we call that specific type papillitis. And capillitis, well, it frequently does come with pain.
Papillitis.
Yeah.
So inflammation right at the visible nerve head. And what kind of pain are we talking about there? Is it like the glaucoma pain?
It's different. And here's a really interesting clue for diagnosis. Pain on eye movement is a really significant indicator for papillitis.
Pain when you move your eyes. Why is that?
Well, think about it. The optic nerve is attached to the back of the eye. When it's inflamed and swollen and you move your eye side to side or up and down,
Mm-hmm.
that movement gently pulls or tugs on the inflamed nerve. And that hurts. It's a very characteristic symptom.
Okay, that's a key differentiator then. Pain with movement.
Definitely something to ask about.
Yeah.
And like other types of optic neuritis, color vision often gets hit hard. Colors might look washed out or faded.
Right.
And our sources also mentioned that this type, papillitis, might be seen a bit more often in children and younger adults compared to the retrobulbar painless kind.
Interesting. So painful vision loss hurts more with eye movement. Think papillitis, especially maybe in younger folks.
Yeah.
Got it. What's the next painful condition on our list from the sources?
Next up is anterior uveitis.
Uveitis, okay.
This is basically inflammation inside the eye, specifically affecting the middle layer, which is called the uvea. You might also hear it called iritis, because the iris, the colored part, is often the most obviously inflamed part in anterior uveitis.
Iritis or anterior uveitis.
Okay.
Okay. What are the key symptoms there?
Typically, someone will have pain in the eye, redness, and often the really significant sensitivity to light. We call that photophobia.
Photophobia, like bright lights are just unbearable.
Exactly. Very uncomfortable. And blurred vision is also pretty common.
Okay. And when you examine the eye, what signs are you looking for?
So when we look with a slit lamp, the special microscope, we're looking for signs of that inflammation in the fluid at the front of the eye, the anterior chamber. We see these tiny inflammatory cells floating around, and sometimes protein leaking from the blood vessels makes the fluid look hazy. We describe this as cells and flare.
Cells and flare. Can you explain that a bit more?
Sure. Think of the cells as like little white specks, individual inflammatory cells you can actually see floating in the fluid. And flare is more like a haziness. It's caused by protein leaking into the fluid. When you shine a thin beam of light through it, it looks like dust motes dancing in a sunbeam. It shows the fluid isn't clear anymore.
Ah, okay. Like a headlight beam in fog.
That's a great analogy. Exactly.
So cells and flare, any other specific signs?
Yeah, sometimes, especially if the inflammation is bad or it's been there a while, the iris, the colored part, can actually get sticky and adhere to the lens that sits just behind it.
Stick together.
Yeah, they form these little attachments. We call them posterior synecchi.
Synechia.
And you might also see little clumps of inflammatory cells sticking to the back surface of the cornea, the inner side. They look almost like little dust spots on the inside of the window. Those are called chorotic precipitants, or KP for short.
KPS, got it. And I remember the sources mentioning that uveitis can sometimes be linked to other things going on in the body.
Yes, absolutely. And this is really important. It raises the question, why is the eye inflamed? Anterior uveitis can definitely be associated with various systemic inflammatory conditions. Things like certain types of arthritis, ankylosing spondylitis is a classic one, or inflammatory bowel disease like Crohn's or ulcerative colitis.
So the eye inflammation is part of a bigger picture.
It often is. The connection seems to be related to the immune system basically getting confused and attacking the body's own tissues, sometimes in the joints, sometimes in the gut, and sometimes in the eye. The inflammatory pathways can be shared.
Right.
So figuring out if there's an underlying systemic cause is a really crucial part of managing uveitis properly. You don't just treat the eye. You need to know if something else needs attention to.
That makes perfect sense. A good reminder that eye problems can sometimes be a window to systemic health.
Nicely put, yes.
Okay, let's shift focus now, maybe to the very front surface of the eye. Corneal ulcers, they sound pretty nasty.
They certainly can be, yeah. A corneal ulcer is basically an open sore on that clear front window we talked about.
An open sore. Ouch.
Exactly. And it's usually caused by an infection. Bacteria, fungi, viruses, they can all cause ulcers. And yes, they are typically very painful. The cornea is packed with nerve endings, making it incredibly sensitive.
So intense pain again. What other symptoms would someone likely have?
Well, besides the pain, you'd probably see quite a lot of redness in the eye. A strong feeling like something is in the eye, that gritty, foreign body sensation. Plus that light sensitivity, the photophobia again, decreased vision, definitely. And often some kind of discharge coming from the eye could be watery or thicker.
Okay. And what does it actually look like on examination?
So the key finding is usually a cloudy or whitish spot on the cornea itself. We call this an infiltrate.
An infiltrate.
Yeah, it represents the actual infection
Hmm.
and the body's inflammatory cells rushing to the area. And usually there's a break in the very top layer of the cornea, the epithelium, right over that white spot.
Okay.
And the appearance can sometimes give us clues about the cause. Bacterial ulcers, for example, often have a really thick pus-like discharge associated with them.
Pus. Okay.
Fungal ulcers might look a bit different, maybe more feathery edges, and sometimes they have these little satellite spots around the main ulcer.
Satellites.
And
Interesting.
then there's herpes simplex keratitis. That's the cold sore virus in the eye. It can cause a really characteristic ulcer pattern that looks like the branches of a tree. We call it a dendritic ulcer.
Dendritic, like dendrites on a nerve cell branching out.
Exactly that shape. It's quite distinctive when you see it.
And you mentioned herpes. Sometimes we hear about herpes eye infections being less painful, but the sources said ulcers are painful.
That's right. While the herpes simplex virus can cause other types of eye inflammation that might be less painful or even painless sometimes when it's actively causing an ulcer on the cornea like this dendritic ulcer, well, all those corneal nerves are involved, and that typically leads to significant pain, often sharp or burning pain.
Okay, so active ulcer equals pain generally.
Generally, yes.
Are there specific things that put people at higher risk for getting these corneal ulcers?
Yes, definitely. Contact lens wear is a major risk factor, particularly for bacterial keratitis.
Ah, contact lenses.
Especially if there's improper hygiene involved. Things like, not washing hands thoroughly before touching the lenses, not cleaning or disinfecting them properly, sleeping in lenses that aren't approved for overnight wear, or even just topping up old solution instead of using fresh.
Right, cutting corners with cleaning.
Exactly. All those things dramatically increase the risk of getting a nasty infection and potentially an ulcer.
That's a really important message for anyone who wears contacts. Be meticulous with hygiene.
Absolutely crucial.
Okay. Is there one more painful condition that our sources highlighted for us to cover?
Yes, one more main category, scleritis.
Scleritis. Okay, what's that?
So this is inflammation of the sclera. That's the tough, white outer coat of the eyeball.
The white part of the eye itself gets inflamed.
That's right.
And what makes scleritis stand out? What's characteristic about it?
The pain. The pain with scleritis is often described as really severe, deep, almost a boring pain.
Boring, like drilling.
Exactly. It's not just a surface irritation. It feels like it's coming from deep within the eye socket. And it can be so intense that it radiates maybe to the forehead, the jaw, or even the sinuses. People often say it wakes them up at night.
Wow, that sounds truly awful.
It can be very debilitating. And along with that severe pain, you'd likely see redness of the white part of the eye, maybe some light sensitivity, tearing, and potentially decreased vision too.
Okay. And does this one also have links to other health issues like uveitis did?
Yes, it does. Very much so. Similar to anterior uveitis, scleritis is frequently linked with underlying systemic inflammatory diseases.
Mm-hmm.
Again, things like rheumatoid arthritis, lupus, Wegener's granulomatosis, various autoimmune conditions.
So finding scleritis might prompt a search for an underlying systemic disease.
Definitely. It's often a sign that there's a broader inflammatory process happening elsewhere in the body that needs to be identified and managed. And just quickly, there's also a form called posterior scleritis, where the inflammation is at the back of the sclera. That can be harder to see directly, but can cause problems inside the eye, like folds in the retina, swelling in the layer underneath the retina called the choroid, or even swelling of the optic nerve head.
Okay, so it can affect the inside too, even though it's inflammation of the outer coat.
Precisely.
So, wow. When we talk about acute, painful vision loss in just one eye, it's really clear from everything we've discussed that there's a whole range of serious possibilities. Definitely not something to just wait out.
Absolutely not. And as we've kind of unpacked, each one-angle closure, glaucoma, papillitis, uveitis, corneal ulcers, scleritis, each has its own distinct features, its own clues.
Mm-hmm.
From the crazy high pressure in glaucoma to the infection causing an ulcer, the cells and flare of uveitis, that pain on movement with papillitis, or the deep, boring pain of scleritis. They present differently.
Right.
But the common thread is that accurate diagnosis and, crucially, timely treatment are absolutely vital to prevent permanent vision loss.
Yeah. And thinking about our listeners, for those of you maybe in your final year of MBBS, prepping for NEET PG, knowing these differentials, how to tell these conditions apart based on the signs and symptoms, that's really core knowledge, isn't it?
Absolutely fundamental. You'll definitely be expected to know these. And for our listeners who might be first-year ophthalmology residents just starting out in clinics.
Mm.
Well, recognizing these patterns, when a patient walks in with a red, painful eye, that's day one stuff.
Hmm.
Being able to quickly form a differential diagnosis, know what questions to ask, what signs to look for, that guides everything you do next.
Mm-hmm. And for our colleagues in general practice, the GPs who are often seeing these patients first,
Yeah.
having that high index of suspicion, knowing when these conditions might be the cause, and understanding the urgency for referral to ophthalmology, that can literally save someone's sight. It makes such a difference.
Couldn't agree more. That initial recognition and prompt referral are so important.
Yeah.
And, even though anyone listening who's just interested in this stuff, I think this whole discussion really highlights how delicate the eye is
Yeah.
and how different problems of pressure spike, inflammation in various layers, and infection on the surface can all lead to these quite dramatic and painful changes in vision.
It really does. It underscores that connection between our eye health and, well, our overall health, and just hammers home the message. If you ever experience sudden, painful vision changes, get it checked out immediately. Don't delay.
Please don't delay.
It makes you think, doesn't it? What other sudden changes in our bodies signal such complex issues underneath? Maybe perhaps digging into the different types of eye pain, like you mentioned, sharp, dull, boring, throbbing, and how those subtle differences might further guide diagnosis. That could be a fascinating area to explore next time.
That would be interesting. The character of the pain itself can definitely offer more clues.